Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome back to Year in Review. As today we talk about new data sets and advances in gastroesophageal cancers. We have a great faculty today, Dr. David Ilson from the Memorial Sloan Kettering Cancer Center in New York City, and Dr. Kohei Shitara from the National Cancer Center Hospital East in Kashiwa, Japan. Today we're here to talk about gastroesophageal cancers, and as in all of our Year in Review programs, we will be talking about the use of non-approved agents and regimens. So check out the package inserts for the various products for more relevant information. As with all of our Year in Review series, I met individually with the faculty in the last week or two to record a presentation going through the papers that we're going to be talking about today. But right now, those presentations, which are really excellent, go through all the data in detail, are posted in the chat room. But when we send out the replay of this webinar, we'll also send that out. We really envision this as a three-part experience with the two presentations. We're not going to talk about all the papers and all the details in the presentation. This is just a list of the papers that were covered in these two really great presentations. You really get a lot out of these presentations. Here's our agenda for today. We're going to start out with kind of a general discussion before we get into specific papers. Then we'll talk about checkpoint inhibitors in GI and gastroesophageal cancers with Dr. Ilson's presentation, and then other therapeutic approaches, particularly targeted approaches with Dr. Shitara. So before we kind of get into this, of course, oncology, biomarkers, every part of oncology now saturated with biomarkers. And I wanted to run a thought by a faculty and let them just chat a little bit about this. And kind of was based on an experience we just had recently at the ASCO meeting where we were doing a program, you might have seen it, on non-small cell lung cancer. And we had general oncologists presenting cases, and we had one case from Dr. Fred Divers of a patient who came in, presented with metastatic non-small cell lung cancer, very, very ill, rapidly accumulating pleural effusions. He wanted to treat the patient right away. He had a liquid biopsy that didn't really show anything, but the NGS was sort of cooking, and he decided to go ahead and give the patient chemotherapy and pembrolizumab. Pretty good guess, but turned out 10 days later when the NGS came back, patient had an EGFR mutation, stopped the pembrolizumab, and then started the osimertinib. And they were talking there about the idea if you have a patient who's really sick and really needs to be treated even before you have the biomarkers in lung cancer, maybe to start out with a chemo backbone and then add in the targeted therapy when you get the results. And I just want to start out with that as a scenario. I mean, really what I want to do is kind of get you to talk about what are the critical biomarkers to obtain in localized gastroesophageal cancer for clinical purposes, and maybe also to get into a trial if you have access to trials, but also in the first-line metastatic setting, what the key biomarkers are and what you all do when you run into a situation where you can't even wait for the IHC to get back. So I'm going to start out with you, David. Can you just provide an overview, I guess really four, or maybe you could add DPD as the fifth biomarker. But can you go through each biomarker, why it's important, and then what you do if, you're at Memorial, maybe you get your results quicker than the community, or maybe you have to send out to get tissue, and that's going to, but sometimes you have to go get the tissue. That could delay you as well. But anyhow, how do you think through biomarker assessment in general in this disease entity, David? And then what do you do if the patient's really sick?
Yeah, well, I think, chemotherapy still remains the core of treatment in metastatic disease. So as your lung cancer case, somebody that needs to be treated urgently, we would initiate chemotherapy with Folfox, probably not an oral fluorinated pyrimidine if they're that sick or symptomatic. The four key biomarkers are usually readily accessible by immunohistochemistry, so the turnaround is pretty quick. And those would include MSI high status mismatch repair protein deficiency, HER2 status, PD-L1 status, and Claudin status. So the MSI high patients obviously are exquisitely responsive to checkpoint inhibitors, so that's going to be a mandatory part of treatment. If we don't have the immunos right away, then we would start chemotherapy. PD-L1 is important because we will reserve use of checkpoint inhibitors if patients are microsatellite stable and they have to be PD-L1 positive 1% or higher. If they're HER2 positive, they should get a HER2 drug as part of first-line treatment. And if they're also PD-L1 1% or higher, they would get a checkpoint inhibitor. And then Claudin, 75% or higher testing. If they're negative PD-L1, negative HER2, mismatch repair intact, then we would combine zolbetuximab with first-line chemotherapy. If all the biomarkers are negative, then they would get chemotherapy alone. Increasingly, the practice at most centers is to check for DPD to pick up that rare patient that has deficiency.
So, Kohei, anything you want to add to that in terms of the patient first-line metastatic setting, but also the localized disease setting? We're going to talk later in a minute about the use of checkpoint inhibitors in localized MSI-high disease, so you certainly would want to know that at some point. On the other hand, if the patient's really sick, they still might need chemo. But how do you think through this biomarker situation and also the patient who's very sick, Kohei, localized and metastatic?
Well, I completely agree with David's comment, particularly importance of biomarkers. Always teach and biomarker is issue and so important to stratify patient to the right combination. But still, chemotherapy backbone is always essential. So we can give chemotherapy while waiting for biomarker assessment or biopsy, especially in sick patients with symptom from primary tumor or peritoneal metastasis, some organ function with liver metastasis or biliary tract infiltration. This is not so many cases in my clinical practice, but still I have such patient in roughly 10 to 20% of my entire population. And for localized population, usually in Japan, we have a more asymptomatic patient because we have a general examination to detect early cancer. But it depends. If patient has dysphagia, we still give FROT-based chemotherapy at the beginning. And now we have approval of durvalumab plus FROT. So we can give it for entire patient regardless of biomarker. But in localized patient, MSI high is particularly important to predict quite nice outcome with a checkpoint inhibitor combination because some of these patients could manage with organ preservation, although this is not a global standard of care.
All right. Well, speaking of IOs, we're going to get into that now with some of the papers that David reviewed in his talk. First, we're going to start out with the issue of MSI-high locally advanced esophagogastric adenocarcinoma. David, you talked about the paper looking at neoadjuvant nivolumab and ipilimumab, also another trial looking at tremelimumab and durvalumab. I'm just going to, when your talk, you go through all the details of these papers. But maybe you can just sort of summarize, and you have both of you put together these really great summary slides with the takeaway message. And here's your takeaway, David. But what's the bottom line in terms of these new trials that have come out, the use of dual therapy, localized disease, and where you see this heading in general, David?
Yeah, I think it's obligatory now to test a locally advanced gastric cancer patient for mismatch repair protein status. It's about 7% of gastric cancers. It's only about 1% of esophagus cancers, but it's a game changer. We know they have a better prognosis, that they do better even with surgery alone in some cases. And there are some retrospective data to suggest that chemotherapy might actually be deleterious to these patients. So I think these two presentations that I review, they're small phase 2 trials, but the results were striking. Both of these studies gave MSI-high GE junction and gastric cancers combination checkpoint inhibitor therapy for up to 2 to 3 months. And pathologic complete responses were seen in 60% of patients, no cancer after 2 or 3 months of checkpoint inhibitors, another 20% near path CR. And then if we look at the long-term outcome, 85+% disease-free and overall survivals were achieved in these patients. So a really stunning result for combination checkpoint inhibitor therapy. So with such high rates of pathologic complete response, then it begs the question, if these patients achieve a clinical complete response, can they be offered non-operative management? Building on the experience now with rectal cancer, where more dostarlimab monotherapy was used. But I think both of these, and at ASCO and AACR, these studies were updated, and the benefit is maintained 2, 3, 4 years out. You're seeing these event-free survivals of 85%. So really, you're curing patients in the vast majority of situations with checkpoint inhibitors followed by surgery. And then the question is, as we alluded earlier, can these patients be offered non-operative management? PD-L1 is not discriminatory here. It doesn't make any difference whether you're PD-L1 positive or negative.
So, Kohei, so many questions come up here. I'm curious, any situations, if you were able to, that you would actually want to use dual checkpoint inhibitors up front, anti-CTLA-4 and PD-1. Would you do that off study if you could access the drug? And what about David's question about whether or not you maybe could even hold off on surgery?
Well, to be honest, in Japan, dual checkpoint like Nivo, Ipi is not approved for upfront gastric cancer treatment for both locally advanced case and first-line population. So we always use chemo and checkpoint inhibitor without CTLA-4 inhibitor for both status. But MSI high is still good candidate even for this kind of treatment. Around half of patients maintain clinical complete response, sometimes which could be managed by non-operative management. Still, this is not, I believe, global standard of care, but based on shared decision process with the patient, if patient had clear repeated negative biopsy, sometimes we discuss about this kind of non-operative management, especially for MSI high patient for either locally advanced or unresectable population.
We actually are presenting a poster at the ESMO GI meeting on the use of ctDNA in colorectal cancer. And it also, Kohei brings up the question of, would ctDNA be a potential avenue to look at in trying to decide whether to hold off on surgery? The patient has a path CR, or if they're ctDNA negative, would that make you more comfortable not going with surgery?
Yeah. Actually, we are doing such clinical trial to follow non-operative management, particularly in patients with clinical response as well as ctDNA clearance. But problem is sensitivity and especially sensitivity is not so high for gastroesophageal cancer compared with colorectal cancer. But with a newer methodology like a full genome an assay, we may have a higher chance to predict outcome. So I believe this is a clearly future avenue.
So one final question back to you, David, which is, you were talking about the work from your institution looking at dostarlimab, a single agent in rectal cancer, where they have these great, incredible results. But what about, is MSI high gastroesophageal cancer, in your view, indirectly as sensitive to IOs as rectal cancer? Is there something special about MSI high rectal cancer that makes it more sensitive? Or would you do better with rectal cancer with double immunotherapy as well?
Yeah, it's not really clear. Our results with rectal cancer, we had essentially 100% clinical CR rate in about 40 or 50 patients. We then had a companion study where we offered dostarlimab to any locally advanced MSI high cancer, and the results were not as good. And there was a small cohort of esophagogastric cancers where the sort of durable complete response without surgery was more in the 40 to 50% range. So I don't think a study will ever be done comparing single agent to combination, but we have these 2 pilot phase 2 studies using combination regimens that were tolerable. And we do know in metastatic colon cancer that combination checkpoint inhibitors are superior. Right. And then we have the data from the Netherlands, the niche study, where patients got, it always impresses me, 2 doses of checkpoint inhibitors, 1 dose of Ipi and 2 doses of Nivo, and then 60% were path CRs, that colon cancer patients, another 20% near path CRs. like 80+% cleared their circulating tumor DNA before surgery, and then after surgery it was 100%. So I tend to be more compelled in the curative setting for using combination checkpoint inhibitors. I really debate the role of chemotherapy. It may be neutral or deleterious. I know we're going to have the study from Germany, the Dante trial, where they gave FLOT and a checkpoint inhibitor to a small, it was all comers. But we tend to try and avoid the chemotherapy in the locally advanced MSI-high patients, given the potential to blunt the immune response and some of the retrospective data that actually showed harm. So, and this is now in the NCCN guidelines. It endorses checkpoint inhibitors in locally advanced patients, and a consideration for non-operative management, and a consideration to either hold or give chemotherapy. So it's hard to make firm recommendations based on small phase 2 trials, but the results are so stunning and compelling that it's actually made its way into the NCCN guidelines.
All right, we're going to move on now to the Matterhorn study, of course, one of the most important studies to come out in the last few years in gastroesophageal cancer, and also talk about Keynote 585. But before we get into that, so Kohei, Shoba in the chat room, and a lot of times in the chat room we don't get a lot of details, but tell me what you think about this. Quote, young patient on FLOT Durva after a cycle of Durva, I don't say how many cycles, but ARF, I guess acute renal failure. Question mark, re-challenge. Any thoughts, Kohei?
Well, it is a little bit tricky question. First, the cause of ARF or renal function deterioration should be quite important, whether this is based on checkpoint inhibitor-related IRE or oxaliplatin-induced renal insufficiency, and it depends on the severity or how quickly it improved. So it depends, to be honest.
Yeah. Well, that's always the case with the chat room cases. We don't have a complete case, but at least it's something to think about. Particularly because of the great results from the Matterhorn study and the need and the interest in trying to get patients on the study. And in David's presentation, he went through the Matterhorn study. I think we all are familiar with this, a really impressive data in terms of events-free survival, but the addition also improved with PathCR, survival benefit. And then we saw an update at the ASCO meeting with more data related to the adjuvant therapy. You put together this great slide comparing the two major studies, Matterhorn and Keynote 585. I won't go back through Keynote other than the fact it was negative. But also I wanted to point out to people this editorial you did in the JCO. I like the title, Keynote 585 fails while Matterhorn succeeds in gastric cancer. What lessons can we learn? This is a quote from the conclusion of that editorial, David, where you basically refer to the Resolve and Prodigy trials in Japan and Korea, looking at IOs adjuvantly and not really being very impressive, and now with Durva, FLOT as really the standard of care. Anything you want to say, David, about these data, about the editorial, and about the clinical standard right now?
Yeah, well, I think what we've learned from Matterhorn is that triplet chemotherapy in a patient who can tolerate it should be the standard of care combined with durvalumab. All the endpoints were reached, and the benefits were independent of PD-L1 status, which is important. So I had problems with the Keynote trial from its inception because arguably it was using an inferior preoperative chemotherapy, a doublet, 5-FU platinum. So from the get-go, it was an inferior regimen. And although we did see, trends, numeric superiority in event-free and overall survival for 5-FU platinum pembro versus chemo alone, and a modest improvement in PathCR rate, at the end of the day, there was no survival benefit. So, and a small cohort in the 585 trial did get FLOT plus pembro, and the results from that cohort were very similar to Matterhorn. They actually added supportive evidence. So I think the conclusion is, in patients who can tolerate it, the triplet regimen is better. And we do know now from Asian studies that there is a benefit for preoperative versus postoperative chemotherapy. The trial of adjuvant immunotherapy after surgery alone was not helpful. So preoperative treatment is the standard. FLOT is the preferred regimen. We should combine it with durvalumab, irrespective of PD-L1 status. And then the ASCO update was important because it showed the patients that did the best, obviously it's intuitive, completed all the adjuvant treatment. So the patients that had the highest event-free survival completed all the adjuvant treatment that was planned. But every subset, patients, all the durvalumab arms were superior, whether they got no additional adjuvant or some adjuvant. Adding durvalumab improved outcome in all of the patient groups. And that was an important update.
So, Kohei, anything you want to add to that? And also, how predictive is PathCR for disease-free survival the way it is in breast cancer? Is it very predictive? And again, any comments about why you think it is that IO didn't work in the adjuvant setting and it does work in the preoperative setting?
Well, it is not so easy question because first Keynote 585 study showed that statistically significant PathCR improvement, but not significant in EFS. But as David mentioned, backbone chemotherapy is different, especially including of cisplatin rather than oxaliplatin. And now cisplatin is not used in clinical practice because oxaliplatin is preferred in terms of feasibility for patient. And in first-line setting, we also have a negative result like a Keynote 62, which also include cisplatin rather than oxaliplatin. So overall, especially as a combination checkpoint inhibitor, all studies support oxaliplatin combination rather than cisplatin. I think this is a unique in gastric compared with other types of tumors. And now we have approval of durvalumab and FLOT even in Japan, and it is also recommended as one of the standard of care. Surely there is a debate about the doublet versus triplet in Asia because of its feasibility, but my clinical practice, I always prefer FLOT based because of our experience and data from non-Asian population. But recent Asian trial in China also support the doublet, so I think this is still option, but I agree with David, FLOT is preferred. And in terms of predictive value of pathological complete response, I still think Matterhorn studies support this kind of relationship between PathCR rate and event-free survival. And although the Keynote 585 was negative from statistical aspect, but magnitude of benefit is not so largely different between pathological response and event-free survival. So I believe we can use this still as a surrogate in early clinical study.
So Kohei, Hassan in the chat room says, if the patient has a CR after durva-FLOT and is ctDNA negative, quote, can we de-escalate adjuvant therapy in that situation, Kohei?
Well, I think this is a burning question, and surely it is better to test in randomized study where the continuation of same treatment is needed for this kind of very effective outcome after perioperative treatment. I think this is a clear topic in clinical trial, and still I couldn't recommend this because of the sensitivity of ctDNA and not supported by randomized studies. So even in patients with pathological response, if patients are doing fine, I still recommend to continue same treatment at the adjuvant, but surely this is a clear important topic for clinical study.
So Shobha again in the chat room says that their surgeons like front-loading the 8 cycles up front because patients have a tougher time dealing with adjuvant therapy. Kind of interesting thought. David, no, we're getting a lot of great comments and cases from the chat room. Another case, a patient is after FLOT durva induction, not much response. Post-surgery, 5 positive nodes, and the patient's HER2 positive. Continue FLOT or switch to HER2 strategy, David?
We have no evidence that adjuvant HER2 drugs convey any survival benefit in HER2 positive patients. We actually have a negative trial that the RTOG ran where they added trastuzumab to chemoradiation, and then patients got a total of a year of trastuzumab, and it had absolutely no impact. So Just because a patient has a biomarker doesn't mean they should get a targeted drug that affects that biomarker. And even though pathologic response does correlate with better outcomes, and these path CR patients really have very low risks of recurrence. I mean, they do quite well. I think the outcome for pathologic CRs to chemo is much better than the outcome when you give patients chemoradiation and their pathologic CRs. You still get 30-40% recurrences. Circulating tumor DNA is not ready for prime time to make decisions yet. And as a caveat, we should look at the data from colon cancer. We talked earlier that maybe circulating tumor DNA is more useful in colon cancer. And in the adjuvant trials, if you're circulating tumor DNA negative, you still have a 20-30% chance of recurring, even if you get adjuvant treatment. So I don't think with the current technology, I mean, it's a research question. I think, can we de-escalate a treatment in a circulating tumor DNA negative patient? I think that's a research question. Whether or not, if a patient's circulating tumor DNA positive after perioperative chemo and surgery, those are high-risk patients. They're ideal candidates for trials targeting new pathways. But the answer is no. Adjuvant HER2 drugs not validated yet. Although the perioperative use of HER2 drugs is very exciting and is an active research question.
And of course, oncologists have been using perioperative or neoadjuvant HER2-directed therapy plus chemo for a long time in breast cancer. Now they're using TDXD preoperatively, which kind of leads into our next topic that David discussed, but I'm going to ask Kohei about it, which is perioperative therapy for HER2-positive esophageal adenocarcinoma. And this paper from the ESMO meeting last fall, I think, David, you were referring to that before, Pembroke, trastuzumab in combination with FLOT. They saw very encouraging results there. They also looked at PD-1 status. Any thoughts about how close we are right now, Kohei, to including anti-HER therapy? Again, oncologists do this every day in breast cancer. Are there trials out there looking at neoadjuvant HER2-directed therapy, not just trastuzumab, pertuzumab, TDXD, and zanidatamab for that matter?
Well, particularly this study from AIO group in Germany showed quite high pathological response rate. Nearly half of patients achieve pathological response, so quite encouraging. And it warrants additional study in large cohort. But to be honest, this kind of combination is still not approved, at least in Japan, and without reimbursement. So we cannot use this drug without official approval. So I believe this is clearly important topic for future global study. Importantly, HER2 is a relatively small fraction. And after Matterhorn, we have a global standard of care. So we can move forward for global randomized study to test a new HER2 targeted agent like this combination with zanidatamab containing regimen in future.
So, David, the next topic from your talk is long-term follow-up of the first-line trials of immunotherapy and chemotherapy. I'm going to just flip through the slides and ask you to sort of summarize it. But while I'm flipping through the slides, would you like to listen to another case from the chat room that I think is relevant here? Here's some of the attraction study, Ipi-Nivo. We'll ask you about that in a second. But here's the case from Susanna, David. 48-year-old man, metastatic gastric adenocarcinoma, MMR proficient, HER2 negative, Claudin negative, PD-L1 CPS of 15, FDG avid gastric, primary retroperitoneal, retrocural nodes, possible liver, lung mets, supraclavicular nodes, FOLFOX Nivo, January 2026, has a complete metabolic response, feeding tube renewed, oxaliplatinum now being held for neuropathy, planned for 5-FU nivolumab, and repeat scanning with surgical evaluation. So any thoughts about this case? She asks about consolidative debulking surgery or with or without HIPEC in a situation like that. Any thoughts about this case, David?
Yeah, I mean, this is not very long into treatment here. So the patient started treatment in January. That's 4 or 5 months of treatment. And so obviously, we see 50, 60% responses to FOLFOX nivolumab, and the higher the PD-L1 score, the higher response. But this is very early on here. We're not ready to do metastectomy in metastatic gastric cancers. It's one thing if 2 years go by and there's a solitary site of disease. This is 5 months. So the answer is a flat no here. With multi-system metastatic disease, it's encouraging, and a normal PET scan doesn't mean there's no disease. You'd have to do testing like MRI of the liver, endoscopy. A normal PET scan doesn't mean no disease. It just means they've had a great response. We really think about thinking outside the box with, adding surgical management in patients that sustain responses beyond a year or two. And we do have data, remember, from the Renaissance trial in Germany, where they planned metastectomy early on in patients getting FLOT, and it was a negative trial. It was actually deleterious to do surgery early on in patients with liver and peritoneal disease. The only patients that may have seen some long-term benefit were the nodal, the sort of retroperitoneal nodal patients. But the patient described here with multi-system metastatic disease, surgery should not even be in the discussion. And that patient should continue chemotherapy. I think it's great if they have a sustained response. And then we might think about debulking surgery, absolutely out of the question. It's just irrational. It doesn't make any sense. This is not ovarian cancer. And we might think about adding local therapies, ablative therapies or surgery after a year or two if they have an isolated site of disease. But the patient, as described, that's a flat no.
So, Kohei, this is David's conclusions of the various trials we just flipped through, looking at tislelizumab, pembrolizumab, nivolumab, and the follow-up now showing some long-term survival, specifically patients CPS greater than 1. Any thoughts about the, quote, tail on the curve here, in terms of, Kohei, in terms of, do you think that adding immunotherapy is bumping up the long-term, maybe even cure in the metastatic setting?
Yeah, I completely agree with this conclusion, especially long-term improvement of survival. We recently summarized our patient who achieved clinical complete response more than 3 years and any recurrence without any additional treatment or after discontinuation. And in total, 51 patients who achieved this kind of almost complete response or possible cure, and most of the patients treated by checkpoint inhibitor or targeted therapy like TDXD. So clearly, gastric cancer patient treatment is getting better. And I just want to mention the biomarker status of this patient. And surely, current indication suggests CPS1 is a criteria to use checkpoint inhibitor. But actual benefit after exclusion of MSI high patient is clearly enriched in patients with CPS 10 or top score 10 or greater. Actually, 1 to 10 is quite borderline in terms of benefit. Surely we can use it, but actual long-term benefit is mainly enriched in patients with MSI high and PD-L1 10 or higher.
So we're going to move on now and go through some of the studies that Kohei talked about in his talk. And we're going to start out talking with anti-HER therapy, specifically David. And one of the issues that Kohei got into, and I'm curious, I'll ask him for his comments too, is the mechanisms of resistance with HER2 targeted therapy. He brings up intratumoral heterogeneity and HER2 loss. You all retest for HER2, breast cancer, not so much. But also heterodimer formation between HER2, EGFR, and HER3. Before I ask Kohei to comment on this, David, anything you want to say about your visions about why HER2 therapy eventually tumor becomes resistant to it?
Yeah, I think we do know a significant percentage of patients, at least exposed to trastuzumab up front, do lose their positivity. In the U.S. trial of TDXD, where we mandated retesting, the dropout rate was only about 10% that actually, lost expression and weren't eligible for TDXD. The other thing to keep in mind with TDXD is there may be some efficacy in low HER2 patients. So So we typically would consider rebiopsying a patient, making sure they retain HER2 positive status. We can also do circulating tumor DNA, looking for HER2 amplification. And there is a significant percentage of patients that does lose HER2 expression. It's not a guarantee that they're not going to benefit from future HER2 targeted therapy, particularly the data. Kohei published this, and there is some signal of efficacy in the lower HER2 expressing patients with gastric cancers. So in the community, I think it's probably less of a practice to retest patients, but typically we'll monitor circulating tumor DNA, looking for DNA for amplification. And again, it's heterogeneous. I mean, if you biopsy one area or the primary and it's negative, some of the metastasis may be positive. It clearly is a heterogeneous, not entirely, one-size-fits-all situation.
So, Kohei, anything you want to add to that, and going beyond heterogeneity in terms of what actually is going on in terms of molecular mechanisms of resistance? And also, maybe you can talk a little bit about this gigantic study just presented at the GI ASCO meeting, now looking at the bispecific zanidatamab with chemotherapy and an IO tislelizumab. First, any more comments about resistance, and then let's start talking about the Horizon study, Kohei.
I might just make a mention just briefly that things like MET amplification, EGFR amplification, ways of bypassing HER2 or other than just losing HER2 or other possibilities.
Yeah, actually, there's a various resistant mechanism or reason of insufficient activity of trastuzumab combination. So not so easy to say one word, but at least if we have around half of patients with remaining HER2 positivity, so we may need a better HER2 targeted agent. And this is mainly driven by HER2 and EGFR heterodimer formation. Some studies suggest that EGFR expression in HER2 positive is related to poor outcome. So that's why this is zanidatamab is an interesting agent which block heterodimer formation between HER2 and EGFR and induce more clustering of HER2, internalization, and downregulation of signal. Also, if we need to compare this bispecific zanidatamab binding site is very similar to that of a combination of trastuzumab and pertuzumab. But unique aspect of this zani as a single agent is to induce immunological reaction, particularly based on complement-dependent cytotoxicity. This was not well observed in previous trastuzumab, pertuzumab in both clinical and preclinical study. So that's why this agent is promising for gastric cancer, and the combination with first-line chemo and IO tislelizumab is being investigated in this Horizon GA01 trial, and it showed a very nice result.
Yeah, and interesting, though, the control arm, though, was trastuzumab chemo without an IO, although they saw benefit, I think, in both patients with a low and high PD-1. David, anything else you want to say about the results of this trial? Is this practice changing? Do you think it's going to be practice changing? And what about the issue of the IO here? Would you give it to everybody or just PD-1 low?
No, I think both arms having zanidatamab involved were superior to chemotherapy traz alone. And remember that the Keynote trial, it took 3 analyses to show a survival benefit for the addition of pembro, whereas from out of the starting gate, zanidatamab, tislelizumab chemo was better than traz chemo. So I think that's an important point to make. And the chemo zani without the tisle was also superior to chemo traz alone. The incremental survival median was about 4 months, and then it went up to 6 months with the addition of tisle. Response rates were pretty comparable. I mean, there was a slight incremental improvement with zani, but the duration of response was also the longest in the tisle zani chemo arm. So I think this is going to emerge as a new standard of care. And Kohei will comment on this, but the benefits were seen irrespective of PD-L1 status. We know in the pembro traz chemo study, if you were PD-L1 negative, you had harm with the addition of pembro. Here, tislelizumab benefited all patients benefited regardless of the PD-L1 status. So, and I think that goes to the fact that zanidatamab is a more immunogenic molecule, and it seems that even with the absence of PD-L1, you get potentiation of benefits. So I think this is likely to emerge as a new standard of care. Right now, the Tisli chemo Zani arm has the best outcome in terms of duration of response, EFS, and overall survival. I suspect that the Tisli Zani, the Zani chemo arm will ultimately show superior survival over Traz chemo, but it probably will take time to mature.
So, Kohei, anything else you want to add to that in terms of practical application? And also, what's your take in terms of tolerability? You know, we've already heard it's been approved in biliary cancer. We heard from the biliary people say the diarrhea is not too bad, but I don't know about in the gastroesophageal cancer. How difficult is the diarrhea there? And do you agree with David's take that this triplet's about to become first-line therapy regardless of PD-1?
Yeah, I think especially for efficacy aspect, I completely agree with the interpretation by David. It showed a quite nice overall survival benefit, particularly with the combination with the Tisli Zani chemotherapy. Median overall survival more than 2 years should be the first opportunity for us to see this kind of long survival benefit in global phase 3 for gastric cancer. And surely component contribution of Tisli is still under discussion, especially after we meter doublet versus control, and then we can compare doublet and triplet to see the actual component contribution. But now overall survival was only achieved with a triplet. It still suggests a difference between triplet and doublet. And in terms of feasibility, diarrhea is more commonly observed with combination, but still within manageable range because only 4% patients permanently discontinue Zani because of diarrhea. And compared with monotherapy, especially in phase 1 or biliary tract cancer, incidence of grade 3 diarrhea is increased, especially combination or interaction between oxaliplatin and 5-FU-based first-line backbone chemotherapy. So sometimes we need a dose interruption of capecitabine and the subsequent reduction of dose of capecitabine is needed. But this kind of adjustment is almost always helpful from my experience. And in this phase 3 trial, a prophylactic use of loperamide is recommended. So I think this is also very important aspect of management after its approval. And I agree with David, it could be a potential new standard of care after its regulatory approval.
So, David, this is again from Kohei's talk. The second trial he talked about was Destiny Gastric 04, phase 3 trial comparing TDXD to RAM paclitaxel, a common second-line therapy. Anything you want to say about this, David? And is TDXD now your typical second-line therapy? In what situation would you not use TDXD?
Yeah, I think this is a practice-changing study because it was a comparison of the old standard of care, ramucirumab paclitaxel versus TDXD, and TDXD was superior as second-line treatment in HER2-positive patients in all endpoints. Progression-free survival, overall survival, response rate, duration of response. We really needed to answer this question because, although TDXD was available to us, we didn't have a head-to-head comparison of the older standard of care second line, which is paclitaxel ramucirumab. So I think this is a practice-changing trial. I think in patients without contraindications for TDXD, it should be the standard of care second-line treatment after prior upfront HER2-targeted therapy.
So, Kohei, anything you would add to that? And any comments about some of the tolerability issues or toxicity issues that come up with TDXD? Of course, oncologists have a lot of experience with TDXD from breast cancer, but now we're seeing this many different cancers with the pan-tumor approval. And two common issues that we started hearing with breast cancer, and I've been asking people outside of breast cancer, is the acute GI side effects that you see with TDXD, nausea and vomiting, how you prevent and manage that, and what your experience is. And also, of course, interstitial lung disease and how breast cancer, they're very, very aggressive about imaging. They want to diagnose it at grade 1 without symptoms. How about your approach in patients with GE cancer? Any thoughts, Kohei?
Thank you. So especially for gastric cancer, approved dose is 6.4 milligram per kg, which was higher than any other types of tumor, for which usually 5.4 milligram per kg is used. This is because of the previous phase 1 trial, as well as some different PK level between gastric and other trial. But to be honest, 6.4 is a little bit tough for some patient. So I usually use multiple antiemetics, including NK1 inhibitor, corticosteroid, 5-HT3, as well as olanzapine, because olanzapine is also supported by a Japanese randomized study for breast cancer to prevent nausea and anorexia. And sometimes I use the reduced beginning dose of 5.4 milligram for patients with elderly or poor performance status. If patients are doing fine with a large volume of metastasis, I tend to use 6.4 rather than 5.4. But still, such kind of dose modification should be considered. And after patient experience some GI symptom, I also discuss with a dose reduction after second or third cycle. I believe this kind of use of antiemetics and dose modification is helpful. For ILD, surely this is one of the issue in use of TDXT. Careful monitoring by CT scan or patient symptom is always very important. And in symptomatic grade 2 or high ILD, we need to interrupt TDXT, and the use of corticosteroids is needed. But in this trial, as well as the other trial, incidence of grade 3 or higher ILD is quite rare. And in this DGO4, we only have a grade 3 or higher in Pacuram arm, and unfortunately, one grade 5 ILD case in Pacuram, but no case in TDXT. So ILD is always important for any type of cancer agent, but TDXT, we need a careful monitoring and management is possible.
So the next study that Kohei talked about in his talk is we were talking about first-line therapy, and the Horizon study was zanidatamab. And here we go with TDXT, chemotherapy plus or minus PD-1 antibody. Kohei talked about some of this preliminary data that was presented using this combination. Kohei, anything you want to say about what we learned about it? Of course, there is an ongoing phase 3 trial. As often happens with oncology, the control arm now, is going to be the old control, so to speak. So I guess we'll have to indirectly compare it to the Zani Horizon study. Kohei, anything you want to say about the initial data that we're seeing with these combinations?
Yeah, this is a March-Cohort phase 2 study to test multiple combination of TDXT. So actually, TDXT monotherapy was also being tested as frontline. But interestingly, TDXT monotherapy showed a little bit lower response rate compared with TDXT plus capecitabine or TDXT plus 5-FU-based treatment. So, as mentioned before, intratumoral heterogeneity is one of the unique characteristics in gastric cancer, which is more commonly observed than breast cancer. And TDXT is effective for some HER2-low expressing model because of the bystander phenomenon, but still backbone chemotherapy is somehow helpful to increase response and PFS. So that's why backbone chemo is important, and anti-PD-1 combination is also supported by preclinical study. And also, as mentioned before, dose of TDXT is different from other types of tumor. But for this kind of combination, clearly this DGO3 study suggests the reduced dose of TDXT and the reduced dose of capecitabine result in more feasible tolerability as well as encouraging activity. So that's why these doses are applied in ongoing phase 3 study like a DGO5 and Artemide study.
So let's talk a little bit about zolbetuximab. Of course, we have the Spotlight and Glow studies that, again, Kohei discussed in his presentation. David, anything you want to say about zolbetuximab? And, of course, the questions we get all the time are about the acute GI toxicity. We hear, slowing the infusion down helps, so maybe lowering the dose. What's your experience with zolbetuximab, and how do you go about preventing and managing GI toxicity, David?
Yeah, I think we've learned that you have to give really an aggressive antiemetic regimen in these patients, including corticosteroids, drugs like olanzapine and palonosetron or ondansetron. So you really need to, and even benzodiazepines. So So these patients early on really need the full complement of antiemetics to reduce this risk of nausea and vomiting. And it does clearly diminish after the first couple of cycles, so it is manageable. But I think it is a real concern. The other issue that seems to be emerging from this class of drugs is actual gastritis and inflammation of the stomach, which also needs to be considered. But when you have a biomarker negative patient that's strongly claudin positive, we have a drug that's available that improves progression-free and overall survival. There's a tail on the curve. So there are clearly immunologic effects of this drug. But the attention to nausea management has to start from day one.
So, of course, the issue's been out there. What, Kohei, in terms of people who are both PD-1 positive and claudin positive, oncologists keep asking me, can we give both? You presented some data of a phase 2, the Illustro study, looking at that. Any thoughts about that? Is that a strategy right now that if you could access it, you would actually use it? Are you using it, Kohei?
Well, actually, this phase 2 study tested such combination, and it showed encouraging PFS and response rate as well as acceptable safety profile. Toxicity is mainly based on each component. And currently, phase 3 study is ongoing, and almost enrollment is completed, and I'm looking forward to see the result. But before that, I couldn't recommend this in clinical practice because phase 2 data is always not enough to support, because previous phase 2 data not always translated in the positive phase 3 outcome. But I hope, but still immature to recommend it for all patients in clinical practice. But looking forward to the phase 3.
So, David, I'm curious, obviously we have an interesting target with claudin, but we have a lot of different ways to target things nowadays. I mean, we have zolbetuximab in terms of a monoclonal antibody, but also here we have an ADC that was looked at in a phase 2 study to claudin. There's, I think, bispecifics out there, I think maybe even CAR T. First of all, any thoughts about the idea of an ADC? Would you expect, or are we going to see the same GI toxicity, David, in this situation? And any thoughts about efficacy in terms of what we've seen up to now, what you're expecting to see in the future?
Yeah, no, I think we've seen a clear signal of activity for claudin ADCs, responses in the 20-25% range, modest PFS, in the 4 to 5 month range. So there is a clear signal. And, there are phase 3 trials that are addressing this in the later line setting versus comparing it to a standard, second-line paclitaxel ramucirumab. So we have to await for the results of those studies, but I think there's a clear signal for claudin ADCs. I think it depends on the drug and the payload, whether we're seeing the GI toxicities. To me, the bispecifics are very exciting. No chemotherapy payload, claudin combined with either targeting PD-L1 or targeting CD3 or 4-1BB for immune cell recruitment. These drugs are very exciting, but we have to pay attention to the potential for GI toxicities from claudin-directed therapies. I think it really varies from drug to drug. I think we're obviously going to see the ADCs compared. Some of the companies are supporting first-line study of these agents in claudin-positive patients. And I'm really excited about the potential for the bispecifics to move into earlier line treatment combined with checkpoint inhibitors and chemotherapy, because the signal in the early phase studies is very strong for the bispecifics and the T-cell engagers.
So again, Kohei, any thoughts about this? I guess we could call it Sony V, the ADC. One of the things about the ADCs that, we're starting to see over and over again is, I think people initially were hoping there wouldn't be any, quote, chemotoxicity. But I think what we're seeing is it does have, they seem to have toxicity, but not necessarily what you would expect. Sometimes you see things a little unusual, some of the ADCs, TROP2, et cetera. Any thoughts about this particular agent and ADCs, the claudin in general, Kohei, in terms of efficacy and tolerability, where you see it heading?
Well, Sonebi, it's MMA including claudin ADC. So still we have a MMA-related AE like a peripheral neuropathy. And usually MMA ADC rarely induce GI toxicity, but this is because of claudin-targeted agents still on-target GI toxicity observed. So always we have each component to induce each class of toxicity. But I still think this is within manageable range. GI toxicity observed in around half of patients, but always grade 1 or less than grade 2. And the use of multiple antibiotics is supportive, as same as a TDXD or zolbetuximab experience. And currently, Clarity Gastric 01 is going to compare this and a later line standard of care. And already it was completed for enrollment, and we are also looking forward to the result. And other ADC agent, particularly IBI343, this was not included in this presentation, but this is a top 1 ADC agent, and it already meets a PFS endpoint to show the superiority compared to standard third-line, later-line chemotherapy in Japan and China study. And we will also assess the overall survival in the near future. So I believe, I agree with David, this is clearly practice-changing platform, and we will also test this in combination with checkpoint inhibitor bispecific agent in first-line setting.
So last topic, paper, I'm going to call this, unless you guys want to try to pronounce it, I'll say Isa-Bren, but really interesting bispecific in squamous cell carcinoma. So again, Kohei, this is your slide. Can you talk about, if you want to try to pronounce it, give that a shot, but really amazing data here. What exactly is this bispecific? It targets EGFR and HER3. What do we know about it in terms of risk and benefit, Kohei?
Thank you. So this is a quite encouraging agent, which already shows activity in other types of tumor, like head and neck cancer, breast cancer, and very recently, this agent is approved for head and neck cancer in China, based on phase 3 study. And the structure is quite interesting as a bispecific with a topo 1 ADC. And the target is EGFR and HER3. And interestingly, affinity is different, more strong or stronger in EGFR and a little bit weaker in HER3. But still, HER3 seems to be important. Compared with EGFR ADC, in preclinical study, it showed a more tumor-specific payload release or more selective tumor activity. So that's why this agent is tolerable without any very strong EGFR-related toxicity like a diarrhea, skin toxicity, but still observed some range of myelosuppression. So careful management, especially for myelosuppression, is needed. But because of this EGFR and the HER3 bispecific structure, it seems to reduce the EGFR-specific toxicity. So I think based on this data, if we can confirm this finding in outside China in phase 2 or for feasibility or some efficacy, I think this is clearly practice changing for squamous esophageal cancer.
So final comment from David. Any thoughts about this fascinating bispecific? And also Hassan in the chat room wants to know what happened with bemarituzumab and FGFR alterations.
Well, I agree with Kohei. I think this is a very exciting drug. We have no effective second-line treatments in squamous cancers of the esophagus. The PFS in the control arm here was 2 months with a response rate of 10%. So I think this drug will likely get approved in China. I think it's going to be a game changer in these patients, and given the activity, it's likely going to be looked at in earlier line therapy. Unfortunately, bemarituzumab, the initial signal was it looked like it was going to have a survival benefit, but then a year out, the survival curves overlapped. So it was really a transient benefit in survival improvement. Very disappointing because the signal from the randomized phase 2 was very strong. We saw improvements in response, PFS, overall survival. But at the end of the day, this was a negative trial for this drug. It did not improve overall survival. And then when we factor in the ocular toxicities and the complexity of giving the drug, I don't think it's going to move forward. So this is why we can't believe phase 2 results. So we have to put things through the rigor of a phase 3 to really demonstrate that we're getting a benefit. So it doesn't mean that we're not going to look at targeting FGFR in the future. I think it's a viable target. We got a signal with this drug that didn't pan out. but we're now excited about looking at FGFR bispecifics and ADCs as an area of promising future drug development.
So, David and Kohei, thank you so much. It wasn't that long ago that we did programs on gastric cancer. We were like, what are we going to talk about? And now, in an hour, we can't even update people on what's going on. There's so much great stuff. Audience, thank you for coming here tonight. Be safe, stay well, and have a great night. David, thank you so much. Kohei, thank you.
Thanks so much.
Have a good one.
Thank you.